Good morning. My name is Srihari Naidu. I'm the director of the Cardiac Cath Lab and HCM Center at Westchester Medical Center. I'm going to provide a shock update 2020, and I'm going to focus on the definition and validation studies since the definition was relaunched last year at SCAI 2019. It all starts with the key considerations in the diagnosis and management of shock. So obviously we have to determine, is this actually shock and how bad is bad? That is followed by, where is the problem? What is the rate limiting step in normalization of the output in the index? And this is where we're going next with several elegant studies by Dr. Kapoor, and you may have heard some of this already today. And then finally, only after you understand how bad is the shock and where the shock is originating from, can we then determine what are the support options in terms of pressors and mechanical support. So the first question is this shock and how bad it's bad? Here's an example I presented last year where you take a car accident, and it's very hard for someone to understand how bad a car accident is until you show them pictures. So this is a car that is drivable, but in an accident. A car here on the top right that is no longer drivable, but in a more severe accident. And finally, a car that was in a severe accident, unsalvageable, cannot be driven, and essentially is total. These are all car accidents, but although the threshold to be in a car accident is very low, the ultimate severity of it is certainly more variable. In shock, we see the same thing. A one-size-fits-all attitude simply doesn't work, and we've seen that over the past 10 years. It hasn't worked in terms of clinical trials, and it hasn't worked in terms of treatment. So here's the IVP2 shock trial on the top right, which had essentially hypotension, hyperperfusion, but relatively minimal lactate, and patients typically weren't intubated, but they were in pulmonary congestion. On the bottom left, though, you have the IMPRESS trial, which had also hypotension, but most patients were intubated, had cardiac arrest, had hypothermia because of that, and had severe hyperperfusion in the terms of both acidemia as well as very, very high lactate levels. These are both cardiogenic shock patients, but I will submit to you that they should be treated differently and certainly should be looked at differently. So that brings us to the shock definition. We want to make a definition that was simple and intuitive, without need for calculation, adds needed granularity in the severity of shock, suitable for rapid assessment at the bedside and reassessment and reclassification as things improve or worsen, should be able to be applied and validated by data sets both proactively as well as retrospectively, should become the new lexicon for communication in all settings at the hospital, in the community, as well as between hospitals and hub and spoke model situations, should provide prognostic discriminatory potential for morbidity and mortality, and finally should be very easy to remember in terms of nomenclature. We came up with this approach, A, B, C, D, and E, with a very broad base of E, which are patients at risk of shock but don't have any signs of hyperperfusion. Stage B, that has compensatory mechanisms, most typically tachycardia, but no signs of hyperperfusion yet. C, where there is hypotension and hyperperfusion with lactate elevation and signs of poor refill and signs of poor circulation. D, where despite efforts, you continue to have those signs of hyperperfusion despite balloon pump or despite pressors. And finally, E, or extremis, where despite all your best efforts, these patients are essentially trying to die on you. They're in ongoing CPR. In addition, we created this risk modifier for arrest, which is a parentheses A modifier. Any patient can have a cardiac arrest, however brief, including defibrillation, and can be in any of these stages. So this is also how we decided that the shock staging should go, which is that there are physical exam findings, biochemical markers, and hemodynamics. What's elegant here is that no matter where you are, you have a physical exam. So that already stages you into one of these stages. And then as you get the biochemical markers back, you may go up or down based on the lactate level or the pH level or other factors here, such as BNP. And finally, if there are hemodynamics, that can also fine tune where you're at, or can even improve things. You can do something with those numbers, improve the state, improve the output, and get you from C to B and then A and home. Or if things are getting worse, it allows you an opportunity to very quickly triage these patients to other levels of care. The ROSC modifier, as I mentioned, can be at any stage. You can have a stage BA shock, which is pre-shock with a simple defibrillation. And then if this patient has signs of hyperperfusion, they become a CA shock. Finally, if you try to improve that with a balloon pump, for example, and they continue to have hyperperfusion, this would be considered a stage DA shock. So from there, after presenting and publishing and spreading the word to the wider community, we want to validate this definition, because it only makes sense after a consensus approach if we're able to show that it's worthwhile. So the first validation was a Mayo Clinic retrospective data review of 10,000 patients in their CICU. And you can see here on the right, after classifying all those patients into stage A, B, C, D, and E, there was an incremental increase in mortality that really had an inflection point at stage D, with marked mortality increase between C and D, and then a fairly extreme mortality, especially in hospital mortality, of almost 70% in stage E. We also had another validation from a German cohort at 30-day mortality showing that stage E actually does quite well. Stage B has a jump to about 25 to 30% mortality. Stage C and D had mortality 50 to 60%, and then finally stage E, about 75% mortality. But what was interesting here is that if you compare them and use stage C, classic shock, as a reference, every stage had a significant difference from one another. So stage A was significantly better than stage B, then stage C, and stage D was significantly worse, and stage E was markedly worse, with a fourfold increase in mortality compared to the reference classic shock. The Mayo Clinic then also looked at all the patients in that registry that was able to be discharged. So these are patients discharged home alive. And you can see here that even if they make it out of the hospital, the SCAI shock stage does track with 1-year mortality quite well. Stage A with 10% additional mortality, B with 15%, C with 20 to 22% additional mortality, and D and E with 25% additional mortality after the in-hospitalization. Interestingly, readmission rates were about the same across each. So if patients have a long admission for cardiogenic shock at any stage, they tend to have a high readmission rate in the first year, and that needs to be better evaluated and understood. Finally, a more recent study about a month ago looked at patients who had out-of-hospital cardiac arrest with return of spontaneous circulation and was deemed to be cardiac in etiology. This is a study out of London. And they found in these patients, now the stage A is no longer benign, but if you had a cardiac arrest, this is the A modifier, stage A with A modifier actually has about a 25% mortality. And that's about the same, 25 to 30% for stage A and B now. Stage C and D had about a 55% mortality, and stage E had an extremely high 80% mortality. When they looked at predictors of 30-day mortality in this cohort, they found age was a predictor, initial non-shockable rhythm was a predictor in some patients, lactate was a predictor in some patients, but these were fairly minor, all three of these. A bigger one was early coronary angiography. If you look at the numbers here, across all A, B, C, D, and E, coronary angiography did appear to improve outcome, but it was routinely performed in stages A through C, so it was not significant because of that. In D and E, it was not routinely performed, but you can see in stage D, it had a marked benefit, about 40% absolute reduction in mortality. In E, however, there was only about a 10 to 12% absolute reduction in mortality. So this is the first indication that A, B, C, and D make a big difference in terms of angiogram and PCI in these patients, but in E, these patients may already be non-salvageable. That is somewhere we have to go and understand better going forward. So the future here, and this is our final slide, is that we need to understand a little bit more about, can we move patients down by early recognition, escalation, transfer, and support strategies, including shock teams, to improve mortality? Can they go down the shock scale and get them out if we use it proactively? Number two, early angiography is beneficial in most stages, but what is the role of mechanical support and shock protocols, especially phenotyping in these patients? We need a lot more education around that and a lot more clinical trials to elucidate that further. And finally, I do think we need rapid SCAI shock calculators to help improve communication, escalation, or withdrawal of support in these patients. So I want to thank the organizers again for this opportunity, and I hope you have a wonderful rest of the conference. Thank you. Bye-bye.